Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the article Referral Practices of Oncologists to Specialized Palliative Care by Kirsten Wendland et al. My name is Eduardo Bruera, and I am the chair of the Department of Palliative Care and Rehabilitation Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. My oncology specialty is supportive and palliative care. This study was conducted by Dr. Wendland et al. From Princess Margaret Hospital and the University of Toronto. The objective of this study was to examine the referral practices to palliative care among Canadian oncologists. The authors were particularly interested in trying to understand the timing of referral and some of the factors that were associated with early versus late referral. Eligible members included all physician members of the Canadian Association of Medical Oncologists, radiation oncologists, and surgical oncologists. This included the vast majority of Canadian cancer specialists. The authors created a survey instrument to assess the domains of physical, demographics, availability, and nature of palliative care services, and the attitudes and beliefs of the specialists regarding referrals to these palliative care services. The surveys were sent to 839 physicians and a total of 603. That is 226 medical oncologists, 302 radiation oncologists, and 75 surgical oncologists returned the survey for a response rate of 72%. 95% of the participants had access to at least one component of specialized palliative care services, and 36% of them had access to comprehensive services, including a palliative care unit, an outpatient clinic, an inpatient consult service, and community services. 77% agreed or strongly agreed that they were satisfied with the availability, and 92% with the quality of the palliative care services available to them. However, 37% stated that they had access to palliative care services that often accepted patients on chemotherapy, and only 42% to ones that often accepted patients who required blood transfusions. 91% of physicians stated that they would always or usually refer patients with uncontrolled symptoms and a prognosis of less than a year. They were less likely to refer patients with uncontrolled symptoms when the prognosis was more than 1 year, or to refer symptom-free patients with a prognosis of less than 1 year. 74% of the respondents felt comfortable discussing end-of-life issues, but only 43% were comfortable providing palliative care. The authors looked at predictors of referral to palliative care by medical oncologists and radiation oncologists. A high referral frequency was associated with satisfaction with service availability, greater number of available services, acceptance of patients receiving chemotherapy, and comfort referring patients to palliative care before they were close to death. Oncologists who had completed a training rotation in palliative care were more likely to refer patients at diagnosis rather than during chemotherapy. In a multivariate analysis, early referral to palliative care, defined as more than 6 months before death, was predicted by female sex with an odds ratio of 2 and access to services accepting patients receiving chemotherapy with an odds ratio of 2.2. This study has found some important differences in the structures and process for the delivery of palliative care in Canada as compared to the United States. Specialized palliative care services are widely available in Canada. 73% of Canadian oncologists had access to outpatient specialized palliative care clinics. This is in contrast to only 59% of comprehensive cancer centers in the United States and 22% of non-comprehensive cancer centers. These differences are important since early referral to palliative care can only occur in settings where outpatient services are available. There was also a striking difference in the availability of palliative care units in hospitals in Canada, 82%, as compared to only 23% in the United States. These findings suggest that Canadian oncologists have superior access to palliative care referrals, both in the inpatient and outpatient settings. This might be partially explained by the nature of the Canadian healthcare system, where universal access to services is available to all citizens, but it also might be explained by the fact that the vast majority of oncologists practicing in Canada do so within academic centers, where palliative care programs are more available both in Canada and the United States. Other important findings of the study include the fact that oncologists were more likely to refer patients with uncontrolled symptoms and less likely to refer patients for psychosocial or spiritual concerns. Those oncologists who had completed the palliative care rotation during training were more likely to refer and also to refer earlier in the trajectory of illness. These findings suggest that oncologists with a better understanding of the scope of services provided by palliative care programs are more likely to take advantage of these services for their own patients. Female oncologists were twice as likely to refer patients early to palliative care. These findings suggest that there were some differences in attitudes and beliefs in oncology practice according to gender, and more research should be conducted to better characterize such gender-related differences. Finally, oncologists were 2.2 times more likely to refer early to palliative care programs accepting patients receiving chemotherapy. One of the concerning aspects of the existing palliative care programs in Canada is that oncologists reported that only 37% of those programs regularly accepted patients receiving chemotherapy. A requirement for patients to be off cancer treatment as a condition for admission to a palliative care program would be a major barrier for early referral. In recent years, the American Society of Clinical Oncology and the Institute of Medicine have encouraged early referral of cancer patients to supportive and palliative care programs for the management of physical and psychosocial distress. These programs need to operate in a fully integrated fashion with the different aspects of the patient's cancer treatment. Early palliative care access results in better symptom control, improved psychosocial distress, decreased cost of care, and preliminary evidence suggests that it might even have positive effects on patient survival. These programs assist oncologists in the delivery of optimal cancer treatment to the patients and in delivering support to their families. The findings of this study suggest that Canadian oncologists have more developed structures in both the outpatient and inpatient settings, but that there still remain processes such as not accepting patients receiving cancer treatment or requiring transfusions that make the full integration with oncology difficult. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.